Thank you. Welcome, everyone. Welcome to the Canadian Global Oncology Workshop. Bienvenue, bienvenue à toutes et à tous. We are thrilled that so many of you have come to join us here in person, here in Montreal, and virtually from all across Canada and from literally around the world. So I'm speaking to a very large audience. My name is Ziv Rossberger, and I'm one of the co-chairs of this meeting. And I wish to acknowledge my co-chair, Dr. Tarek Hijal, and Dr. Arjuri Tsimikalis, who is the program director of the McGill Global Oncology Program, under whose auspices we are carrying out this workshop. I also initially want to acknowledge the immense and tireless efforts of our organizing committee. Nell, Bahar, Doctors Melissa Henry and Annette Kerner, and last but not least, Ben Howard, who is manning the controls of this website, the Homan website, from a remote place somewhere outside of Philadelphia, and I don't actually know where that is. It might be the North Pole, but I'm not sure. But he's doing that along with Jonathan from our communications department here at McGill. We have many sponsors. You can see some of them, probably noticed them on the website, but we must give special thanks to the Gairdner Foundation for their immediate and financial support over the time that we've put this together. So a shout out to the Gairdner Foundation for really supporting our efforts. I believe that we as a group have put together an amazing program beginning this evening with our opening plenary. And we will continue, just to remind you, both here and those of you who are online, that we will continue from 9 a.m. Eastern Standard Time sharp tomorrow morning for the day. So a little bit of housekeeping just to orient everyone online. If you agree and wish to network with others or contact others that are here or online, please list your name and coordinates and your interests in the chat for the rest of the participants to view. We will maintain this list on our website after the meeting. This workshop will be recorded in its entirety and be available later for online viewing. Each session will have a moderator who will introduce themselves and their speakers. We're hoping to have 10 minutes or so at the end of each session for discussion and debate and questions. There's a microphone here in the room, and those of you online on Homan may write your questions and comments in the chat, and they will be read out to the audience in turn. We'll end each session on time, hopefully today and tomorrow, to ensure that the next session begins in a timely fashion, and we give our time and attention to all of the speakers who really have made extraordinary efforts to both be available live, to pre-record their presentations, or to be in person. And we thank all of you for doing that. Finally, for those participating here in person, just to make everyone else jealous, dinner is being served as we speak. Sorry about that. So I'm going to introduce now a couple of people, but first and foremost to make a couple of opening remarks, I'd like to introduce Professor Eduardo Franco, who is Professor and Chair of the Department of Oncology here at McGill, to give us a few opening remarks. Eduardo?
Yeah, indeed. Thank you very much, Dr. Rossberger. Ziv, such a pleasure to be here with you and give the welcome from the Department of Oncology, the first Department of Oncology in Canada, and the opportunity to be in this very impressive place here at the Faculty Club in Montreal. Again, those of you in connecting via video conference, another element for you to be jealous. You know, this room here is impressive in many ways, and actually it's a symbolic element of how much we have progressed in being today together. This used to be the billiards room, and there were billiards tables here and a bunch of chairs here. And this back in the days when only men would attend the faculty club, and they would come here to smoke cigars on their pipes here. So now we're a completely different environment. It's so conducive for the sorts of things that we want to attain today and tomorrow all day. So without further ado, just thank you very much for joining us today here. And it's such a pleasure to host this at McGill. And on behalf of the organizing committee, so I wish you a great conference tomorrow all day. I'll be attending, somewhat in person, somewhat via distance. So welcome, everyone.
Thank you, Eduardo. I'd like to introduce now to say a few words Dr. Danielle Roden, who is the director or chair, I don't know what the title is exactly, of the Canadian Global Cancer Network, who is our partner in this event. Dr. Roden is a radiation oncologist at Princess Margaret Cancer Centre in Toronto and an assistant professor in the Department of Radiation Oncology at the University of Toronto. And she's recently been elected, I believe, to the board of directors for the Union for International Cancer Control, the UICC in Geneva. And her interests are in breast cancer and hematologic malignancies. She's a health services researcher, interested in technology assessment, global health systems, and large databases. So, Dr. Roden.
Thanks very much, Ziv, for that warm introduction. It's so nice to be here in person, back at my own alma mater. On behalf of the Canadian Global Cancer Network, it's truly my pleasure to be here to kick off the 2022 Global Oncology Workshop, which has really been graciously hosted and executed by the McGill Global Oncology Program. This is an event that's co-organized by the Canadian Global Cancer Network, which is really a grassroots network of Canadian institutions and individuals committed to advancing global oncology. There's a lot been written about the power of global health networks to create change and really to connect individuals and organizations that are dedicated to addressing major global health challenges. And a lot of these networks have been identified as major determinants of how we understand global health problems and how we include and engage different individuals to advance core issues, and the attention and resources that different problems receive. Over more than 2 years, many individuals from academic medical centers, NGOs, and the Canadian Partnership Against Cancer have been working together to strengthen the field of global oncology in Canada and to develop collaborations with each other and with our global partners. This Global Oncology Workshop represents an important opportunity for network members and others looking to engage in global oncology from within Canada to convene, to share new knowledge and perspectives, and to discuss and debate important issues in the field. This event this year, hosted by McGill, builds upon conversations that were started a couple of years ago, initially at a workshop hosted by Princess Margaret and the Canadian Partnership Against Cancer. Last year, the workshop hosted by Queen's University, and now we're here in Montreal physically together for this year's workshop. The workshop tonight is timely as our network's web presence is officially live this week and can be viewed on the Canadian Partnership Against Cancer website. And I'd like to just take a moment as well to acknowledge Leslie Chalklin, who's the Princess Margaret Global Cancer Program Manager, who's done a tremendous amount of work to support and the development of the network over the last 2 years. So I'll close just by expressing my deep gratitude to the McGill Global Oncology Program and the Department of Oncology for hosting this wonderful event this year, and to everyone who's made the event possible. It's now my pleasure to introduce Dr. Simon Sutcliffe, who will be moderating the opening session of the workshop on reducing the burden of cancer in low and middle income countries and the power of strategic collaboration. Dr. Sutcliffe is a clinical oncologist and president of Two Worlds Cancer Collaboration, a nonprofit society and charitable foundation aimed at bridging global disparities in cancer control. He's an adjunct clinical professor at UBC and an associate scientist at the BC Cancer Research Centre and serves on a number of clinical and scientific advisory committees. He's the past president and CEO of Princess Margaret Hospital and the Ontario Cancer Institute, as well as later at the BC Cancer Agency. And he's the recipient of numerous awards recognizing his many important contributions to cancer control within Canada and globally. Dr. Sutcliffe, over to you. Thanks, everyone.
Thank you, Danielle, for that kind introduction, and welcome everyone to session 1 of the workshop entitled, How Can We Reduce the Burden of Cancer in Lower and Middle-Income Countries? The Power of Strategic Collaboration. We're all aware of the rising burden of cancer, particularly in countries limited in their ability to respond societally, medically, and financially. Such countries, comprising the majority of the world's population, face many imperatives relating to social determinants of health, human development, and competing health priorities with limited resources and economic growth. The gap in the health and development between the higher resourced and the lesser resourced is wide, a source of societal and political distress, and a substantial challenge to the goals of fairness, equity, and healthy global populations. As noted, the Canadian network was established in 2020 to develop a pan-Canadian approach to global cancer control that could facilitate effective and ethical partnerships, strengthen capacity and cancer control systems, and position Canada within the global health agenda. Key elements of this initiative include network development, partnerships, education and training, research and advocacy. NetShop workshops have largely focused on what do we know, what do we need to know, and what are the key issues impacting global cancer control. The purpose of session 1 today is to move the conversation towards what might we do and how would we do it. There are clearly many ways that the Canadian network could harness the collective will of Canadian institutions to advance cancer control. They could be internal to Canada, for example, cancer control for underserviced populations, Indigenous peoples, growing new immigrant populations, etc. Or they could be external to lesser resource countries. They could be largely academic, building scholarly capacity in Canada to support global initiatives, or they could be clinical service oriented, helping capacity building through collaborations in lesser resource countries or global regions, or indeed it could be both. Session 1 will illustrate opportunities to foster a discussion as to what is it that we might do. There is no implied judgment, re better or worse or good, bad, right, wrong, only an impetus to place learning and thinking in the context of doing to improve cancer control as a Canadian network. Global health and cancer control is increasingly recognized as a legitimate academic pursuit, both for institutions and health professionals. Networks to harness the contributions of many partners within a more cohesive strategy are becoming established. The London Global Cancer Week, the UK Global Cancer Network, our own Canadian Global Cancer Network, regional networks such as RINC in South America and Aortic in Africa, and networks based upon comprehensive cancer centers, for example, the Tata Memorial Hospital in India. Given the need to establish increased capacity to control cancer at a population level, and recognizing that this will entail depth of training, skills, and experience, scaling interventions to population level, and establishing the scope of activities to achieve comprehensive cancer control, could networks and networking become a vehicle whereby individuals and institutions can engage in comprehensive cancer control within a coherent framework whereby the whole becomes possible through the sum of the collaborating partners? Could global cancer control advance from opportunistic engagements to improve aspects of cancer control to strategic collaborations to address the health system needs of lower and middle income countries as they try to reduce the burden of disease. There will be 3 keynote presentations illustrating how organizations comprised of multiple partners are approaching the issue of reducing the burden of cancer in lesser resource settings. The focus of the presentations is not so much about why does the organization exist and what does it do, but rather how does the organization do what it does? The way the collaborations and partnerships work to advance cancer control in lesser resource settings. In short, how can we make collaborations mutually engaging, productive, focused on reducing the burden of cancer, and beneficial for collaborating partners and the populations of lesser resource settings? The first keynote address will be presented by Dr. Ben Anderson. Dr. Anderson is a professor of surgery and global health medicine at the University of Washington, USA, and the surgical director of the University of Washington Breast Health Clinic. He has chaired the Breast Global Health Initiative, pioneering the development of resource-stratified guidelines in lesser resource countries. In 2020, Dr. Anderson joined the World Health Organization, assuming the role of Chief Medical Officer for the Global Breast Cancer Initiative, launched in March of 2021. Dr. Anderson's presentation is entitled Global Breast Cancer Initiative, Resource-Stratified Guidelines, and Strategic Collaboration. Dr. Anderson.
I'm very pleased to be able to present to you today. I'm sorry that I cannot be attending the meeting live. What I was asked to address today is the Global Breast Cancer Initiative, which developed resource-stratified guidelines, talk about how this related to strategic collaboration over the years that made this work possible. My prior work was with the Breast Health Global Initiative based in Seattle at the Fred Hutchinson Cancer Research Center with support from Susan G. Komen for the Cure. I'm now at the World Health Organization based in Geneva, where I lead the Global Breast Cancer Initiative. My name is Dr. Ben Anderson. We're going to begin by talking about evidence resource guidelines and adaptation. That's the need. We'll talk about the development of resource stratification and how the Breast Health Global Initiative had developed this. We'll talk about how others have carried this work forward with harmonized regional guidelines. And finally, we'll talk about the Global Breast Cancer Initiative itself, which is an end product of this work. Ideally, we would prevent cancers. If we could stop cancers from occurring in the first place, that would be the best solution. But when primary prevention is not feasible or realistic, then we need to go through this cycle of early detection, diagnosis, and treatment. And therefore, the challenge becomes, how does one establish health systems that support those efforts? In 2004, my group first went to Ghana, West Africa, in order to try to address this question of when is a country ready to begin breast cancer work. This is the Komfe Anoche Teaching Hospital, a 1,000-bed hospital. It has a dental school, a nursing school, and a medical center. And this is the breast center for that clinic back in 2004. The women are lined up to be seen for breast health. This is actually a short day because there was a nursing strike taking place that day. This was the earliest breast cancer that I saw when we presented there. Here's the diagram showing the 10-centimeter mass in the woman's left breast. Much more common was this sort of disease, where the disease was locally advanced, ulcerating through the skin, and where supportive and palliative care was really the most that one could anticipate being able to provide. They had a multidisciplinary clinic. And what you see in the front, in addition to the clinicians around the table, the gentleman in the front is the one pathologist for this 1,000-bed hospital. The woman to his right was the one radiologist for this 1,000-bed hospital. And so this created a bottleneck because those were not adequate services for supporting cancer services, which of course was the demand. Advanced stage of diagnosis was a major obstacle. Patients would have mastectomies without adjuvant treatment. They weren't hooked in for systemic therapy. And if you take a locally advanced cancer and only operate on it, you cannot anticipate there would be improvements in survival. There was no post-surgical radiation following mastectomy. With this 1,000-bed hospital, we encountered a problem that we had not anticipated, and that was that the pathology report would typically take 4 to 6 months to generate. And that was an example of a problem that really was impeded any potential for moving forward. And so that was the seed for this idea of what is it that makes resources essential that we have to move forward on, and was the basis for resource stratification in the beginning of the Breast Health Global Initiative. So in terms of partnership, the goal of the partnership was not the partnership. The goal of the partnership were the outcomes that were anticipated. And I think that that's a very helpful strategy. It's what are we doing rather than who are we? And we held a series of 6 global summits between 2002 and 2018. It was in that second summit, after that visit to Ghana, that we developed this concept of resource stratification. The idea being that while we have excellent guidelines for the management of cancer, we don't have ways of prioritizing, because those high-income country guidelines like NCCN or ASCO or ESMO wouldn't provide direction on how one builds if you have some but not all of those tools. And so we defined this concept of resource stratification, saying that every standard resource fits within a scheme. Some resources are basic or core, meaning that you cannot do without them. A pathology report in 6 months is an example of that necessity. The next level we defined as limited level resources, second tier resources that would make major improvements in survival. Most of the drug therapies would fit in that because we have prospective randomized data showing that patients live longer when we use these medications. We defined another tier as enhanced level. Those would be services that might not be influence survival overall, but would nonetheless be very important for other reasons. Breast conservation therapy, doing a lumpectomy with radiation rather than mastectomy, is an example. Women don't live longer because you do a lumpectomy with radiation, but it does make the therapy more appropriate and potentially would increase participation. And then we identified a group of resources that one should not focus on. And these tend to be the resources that we talk the most about in our high-income settings, where we talk about PET scans or MRI. No one lived longer because they had a PET scan. And it's a misplacement to be thinking about PET scans when the standards like diagnostic mammography and ultrasound are not yet set up. And so based upon that scheme, we created this 4-tier system for each of the areas of healthcare systems: early detection, diagnosis, and treatment by stage. And therefore, what we were defining was this framework for building a framework for gap analysis to identify where our limitations might be. We're all familiar with the mammographic screening guidelines that have, on average, shown a 20 to 23% benefit in mortality for women who undergo screening between the ages of 50 to 69, potentially extended to 45 to 74. One of the problems was that we talked to low and middle income countries as if that was the first step, that was the first thing, when in fact the resources for setting up mammographic screening are huge. And so instead we said, well, where do you start? Where you start is a clinical exam and taking a history. Those are basic. And if you cannot do that, it's very difficult to identify clinical findings like palpable lumps. Diagnostic imaging comes before screening because you have to be able to do those diagnostic workups. 10 women presenting with a lump, 1 of them will have cancer. We have to be able to sort them out. And screening is in that enhanced level. When do we start? On whom do we go? It was very interesting. We were able to bring together experts from the American Cancer Society and Tony Miller from Canada. And while they may disagree upon when we screen, they don't disagree on the prioritization. That's a resource stratification approach. So WHO started talking about early diagnosis. That is, we need to focus on the cancers that we can see or feel before we address screening, where we're looking at women who are asymptomatic. If I screen with mammography 1,000 women, 150 will need a diagnostic workup to find perhaps 7 cancers in the group. Whereas if we wait until they have small symptoms, the resources to do the diagnostic workup is much closer to 1 in 10. The question, of course, is, if we wait for symptoms, is that too late? Are we waiting too long in order to do this? Well, we now have evidence about this. In Mumbai, and there actually are 2 Indian trials, but the Mumbai trial reported last year randomized women to screening with clinical breast exam and then followed over a 20-year period every 3 years. They successfully downstaged disease with a higher fraction presenting with stage 1 or 2 disease rather than stage 3 or 4. And there actually is a mortality benefit in this trial for women 50 and above. It's really interesting to note the data mirrors those of screening mammography. The point of this is not to criticize mammography. We're not getting into that debate. The point here is to recognize that when one doesn't have a screening setup, when it isn't a realistic resource, using clinical evaluation first is where we start. And therefore, with this resource stratification, we recognize you have to move on to treatment, being able to do a modified radical mastectomy, standard drug therapies. These are basics in order to move forward. And that's really got changed by WHO when the decision was made through this resolution to support resource-stratified guidance. So WHO actually adopted this approach to base resource stratification as this fundamental approach, looking for cost-effective interventions, and to harmonize these with technical assistance with other groups. So you see, by beginning with the evidence and the task, that's what became the basis for partnership. And I think, again, it gets to what are we going to do rather than who are we is the key question. Now let's talk about what others have done with this resource stratification. Initially, when we proposed resource stratification, most groups, including ASCO and NCCN, said, well, no, you can't do that because that's certifying substandard care. And we countered, no, that's not correct. We are absolutely asserting that one needs to build systems, and you need to go in an order, African country representatives, to look at the system and say, how is it that we can address cancer in sub-Saharan Africa in ways that are appropriate or standard? And they created these harmonized guidelines in which those African experts looked at the standard NCCN guidelines and through this color coding said, this is what is standard for us. So they took a highly evidence-based guideline and then selected according to their current environment. What was most exciting about seeing this work presented in Paris at the UICC World Cancer Congress was that the African colleagues presenting this presented as our NCCN guidelines. So one of the things to think about in global cancer is you cannot helicopter in, fix things, and leave. You're building systems that are sustainable, and there needs to be ownership on the part of those who are using it, who are actually, because it is their system and their needs. NCCN now has harmonized guidelines for a very broad range of malignant diseases. We also have groups like CCAN. CCAN points out that when we talk about guideline development, guidelines are not a document. Guidelines are a process. It is the process of guideline development that creates health system strengthening. One must avoid unrealistic targets. You need to make bite-sized steps, and you realize that the process is iterative and repeated. And to that end, resource stratification is a framework for multidisciplinary planning, gap analysis, and assessing feasibility. I'm finally going to talk about the Global Breast Cancer Initiative now here at WHO as the culmination of that partnership work that led to this place. The objective of the Global Breast Cancer Initiative is to reduce breast cancer mortality by 2.5% per year, which, if you do the math, would save 2.5 million lives over a 20-year period. We created 3 pillars, which follow essentially the same framework that the original work of the Breast Health Global Initiative guidelines had. Health promotion for early detection, which is an educational initiative, timely breast diagnostics, and comprehensive breast cancer management. But what we really are doing is mirroring 2 ways of thinking about it. the public health sciences approach, where we know we've succeeded in high-income countries in being able to improve on outcomes. And the question becomes, how do we translate this to limited resource environments? And the thesis is using clinical management, the things that worked in the 1990s to create that 40% reduction in breast cancer mortality that's been seen in North America. How do we use these same clinical strategies? We did an analysis to ask the question, what are the characteristics of healthcare systems that have been successful in reducing breast cancer mortality? And in multivariate analysis, we identified two processes. One is higher level of universal health coverage, that is, do we pay for it? And the second is number of public cancer centers per 10,000 cancer patients. In other words, what this analysis of a very large number of health systems variables, when we got down to what is essential, it is payment and it is access. And this is very fundamental to our conclusions. We're often told that in sub-Saharan Africa, you cannot make improvements. And this gets to the point that you need to collect data. Here we have the African Breast Cancer Disparities and Outcomes study that looked at 5 sub-Saharan African countries. The blue bars are the actual 3-year survival that they identified by following these patients over time. But they found that if they could improve treatment by allowing patients to get all the way through treatment without abandonment, downstaging disease so that greater than 60% of the cancers were stage 1 and 2 at diagnosis, and by creating access, by addressing the social inequalities. Those colored bars is how much improvement could be obtained in sub-Saharan Africa. And so this gets to the point that by following what the principles that we know about, this is how we can make major improvements in outcome, and they are the basis of the pillars. So again, partnership based upon conceptual frameworks that we can agree on based on evidence. This is treatment abandonment. We talk about drug procurement. Do you have trastuzumab or do you not? But the real problem is not the first dose of chemotherapy. The real problem is the last dose. So here, the orange area under the curve, those are patients that began treatment within 3 months in sub-Saharan Africa and completed it. It's about a completion rate of 50%. Think of that. That is the worst of all worlds if you do half of the doses of chemo. Then you get the side effects without the benefits. So as a group in our partnership, we need to make sure that we're identifying the real core problems and then coming up with practical and meaningful solutions. So in summary, we now have mandates in the United Nations that puts non-communicable diseases in general and cancer in specific on the global health agenda. This sets the stage for change. Breast cancer is an index malignancy. If you can do breast cancer, it is the most common cancer globally today. If you can do breast cancer, there's a lot of cancers that you can do going through this resource-appropriate stratification of early detection, diagnosis, and treatment. Resource-stratified guidelines provide this framework for an evidence-based, phased implementation strategy guided by the principles of implementation research. And as such, we believe that the Global Breast Cancer Initiative can be a catalyst for change by developing approaches that are relevant to women's cancers and women's health throughout their life continuum. I would like to acknowledge and thank the World Health Organization, within the Department of Non-Communicable Diseases, our chair, Dr. Bente Mikkelsen, who's been supporting these efforts. Thank you very much for your attention today.
So thank you very much for that, Ben. I'm sure, as everyone can appreciate, there is a lot of learning and wisdom in the comments that Ben has made over and above the purpose of the Global Breast Cancer Initiative as an entity. So our second presentation is going to be given by Ms. Karin Homan. She is the president of Strategic Health Concepts, an organization that has worked in cancer control for over 25 years, providing strategic planning and technical support for the US Cancer Control National Partnership, as well as the International Cancer Control Partnership. Today, we'll hear from Karin about how these partnerships are designed to coordinate a multidisciplinary approach to cancer control at the national level. Her talk is entitled Key Elements of National and International Cancer Control Strategic Partnerships. Karin.
Hello, I'm Karin Homan, President of Strategic Health Concepts, which is an international public health and healthcare consulting company. And I'm delighted to be with you today to provide you an overview of two very strategic partnerships that exist in cancer control, both at the US level as well as globally. So today what I'd like to do is cover and do pretty much like case studies of two collaborative partnerships. They are the US-based National Cancer Control Partnership as well as the International Cancer Control Partnership. And then we'll really kind of dive in and look at what makes these partnerships successful. So both of these partnerships have been in existence for a while. The US National Partnership has been around for 20 plus years, and the International Cancer Control Partnership has been in existence for 10 years. Looking first at the CCCNP, we as a partnership, when it first began, really looked at what are we trying to do? What's our purpose? And it was to really develop and support a national movement in the US for local communities, states, tribes, jurisdictions to come together, different stakeholders, different disciplines to come together and reduce the burden of cancer in their communities. The mission of this partnership was to support those coalitions or stakeholders or partnerships at the local level in not only developing and implementing cancer plans, but supporting them as far as providing them with training and technical assistance. And the history of the National Partnership is that it really was an informal gathering of some key stakeholders that said, let's try to reduce our duplication, let's try to increase our coordination, and now we have 17 members of the partnership in 2022. Here you can see the different organizations that make up the U.S. Cancer Control Partnership. We've got a variety of government, philanthropic, academia, and focused public health, different types of organizations involved. The contributions that the National Partnership provides to the field is that we really try to look at the needs and the gaps and opportunities as far as technical assistance to coalitions. So we ask them a lot what they are needing and how can we best provide that support to them. We conduct trainings on both the critical skills and different kinds of knowledge that might be emerging to create, implement, and evaluate cancer plans. And as a whole, as a partnership, we really advocate for cancer control efforts, recognizing it's a part of a piece of a bigger chronic disease burden that all of these communities in the U.S. bear, but also where does cancer fit into all of that chronic disease landscape. Also, we provide resources, not necessarily money, but the partnership comes together to try to leverage different resources such as staff and expertise and existing programs and networks. And then as a whole, we try to offer expertise in our leadership to the nation on cancer control. So we have a strategic plan, which is critically important for us to follow and to evaluate our progress. The three areas of the strategic plan, we have major goals in those three areas, which is facilitate and provide support to coalitions, to coordinate national cancer control efforts, and also to leverage partnerships so we're advancing health equity through those coalitions and helping them look through their efforts through a health equity lens. The partnership works because it's a very collaborative, kind of volunteer effort, and we have loosely structured ourselves in this way. There is a leadership group. We do have a communication and evaluation advisors, and we also develop work groups and ad hoc groups as needed without getting too stuck on formalities. We say, hey, we need to pull together some people for maybe half a year and think about this and think about what we can do. Then we do have 4 existing groups right now, which are sustaining coalitions, vaccine preventable work groups, CRC screening work group, and health behaviors for cancer survivors. Those work groups are focused on those areas in the cancer control continuum and how they can provide support to the coalitions, and really assuring that each partner involved is bringing to the table their expertise, their perspectives, and as much as possible, avoiding duplication and looking for opportunities to come together. Key features of the partnership are that it's multi-sectoral, as we saw in that slide where it showed all the different logos. It's really looking at where can we add value as a partnership. There's a lot of people in this space, a lot of people doing different things, and so what can this partnership bring to the table that's different than other partnerships or other agencies that are out there? As I mentioned, the partnership is pretty flexible. We really stress the idea that form follows function. So if we see a need, we look at our existing structure, our existing work groups, and say if we need to look in to see if we needed to make a change or adapt any of our operating procedures to accommodate those different needs that may arise. We are very committed to involving our constituents, getting assessments from them, involving them in the development of technical assistance, and working with them throughout the year to really have our pulse on what they need, as well as making sure that there's feedback that they are being able to provide to us on their needs. And then we prioritize activities each year based on those needs and different priorities that are happening in the nation on cancer control. Switching to the International Cancer Control Partnership, that was formed about 10 years ago. We have 21 partners. Over those 10 years, we've supported 75 countries, and that partnership is structured so that there are 3 working groups, and one of the goals of the partnership is to advocate for and communicate about the importance of national cancer control plans, so we feel very strongly about putting out publications. The vision of this partnership is that all countries, especially low and middle income countries, have and are implementing a resource-appropriate national cancer control plan. We really encourage countries that they look at their own data, whatever they have, they look at their health systems, whatever they have, and their resources, and develop a plan that's appropriate for them. The mission of the ICCP is to provide that leadership guidance and expertise so countries can, on their own, but with support, develop and implement and evaluate their national cancer control plans. When the partnership first came about, it was fairly loose and formal. As a few years went by, there was a need to become a little bit more organized and structured in how we did our work. So we developed a strategic plan that has 6 priority objectives, and every year we go through a partner resource commitment process where the organizations that are part of the partnership commit to how they can contribute to the different priorities within the strategic plan. Also, we have a document that is terms of reference, and we really view that as operating principles and procedures that provide written information for us about roles and responsibilities, how often we get together, that type of thing. The goals in the ICCP strategic plan are that we really are coordinating and leveraging and assuring non-duplication of efforts in this area. The second goal is that we're providing some valuable resources as well as technical assistance and trainings to countries as they develop and implement their plans. And then the third is to become a partnership that people look towards as credible and as helpful, and is really a place where that they can get some answers to their questions. What's very important to this partnership is that we're coordinated, and so we have on the partnership, we work within the partnership with the UN agencies such as WHO and IAEA and IARC. We certainly involve the country very, very much. This is about them, and they need to drive the process. And then wherever we can, we help support them in that process. Here you can see the different partners that ICCP is made up of. We have, again, very much like the national partnership in the US, we want it to be multi-stakeholder, multi-discipline. We look at different regions of the world. We look at different disciplines. And we have government agencies as well as a variety of different philanthropic agencies. This graph shows the support of the ICCP in the development and declarations of various UN agency declarations that support the development and implementation of national cancer control plans. So again, the partnership is focused on those plans, and we are looking at very high level resolutions, declarations that have been made, and we really work to support those and look at where the value added piece of the partnership can come into play. So you'll see in 2012 we started the partnership, then we began some training and technical assistance efforts all the way through to we're in 2023 going to take a look at every country's, low middle income countries, cancer plan and do a review of those and in a summary kind of way. So ICCP offers different kinds of technical assistance. We help folks that want to develop a cancer plan, that maybe have a plan, but they're not sure how to begin implementing the plan. When also countries develop a new plan, often they'll ask us to review their plan and look for strengths or weaknesses and offer some advice on how they can bolster their existing plan. We offer also an ECHO, which probably most people are familiar with, but it's a telementoring program that countries who are implementing their plan come together once a month and talk about their issues and their challenges and their solutions. We also have a great portal. It's on the web, and we have every single that we know of, every single country plan, and lots of resources for what should go into a cancer plan. How do you work with different disciplines? How do you evaluate plans? Things like that. And then the other thing that we offer is if a country has specific needs, we try to connect them with the right expert. We really view this as a relationship with countries, and that we don't just kind of have a one and done training or interaction with them, but that we work with countries that either have no plan but want to have a plan, and we're encouraging and try to help them get that political will in their country to develop a plan. Again, once they do have a plan, we help them look at reviewing it and evaluating it and implementing it. And then that ECHO program also helps with the implementation of their plan. What we really are wanting to, in the long run, is have that country see program and policy change that reduces the burden of cancer in their country. I mentioned the ICC portal and resources. I hope you can visit it. It's a very rich resource of many different documents, tools, guides, and it also allows countries to request technical assistance through that resource and that portal. Here you can see the technical assistance that the ICCP has offered over the years. These are the breadth and of where we have worked, as well as looking at, this shows you the different types of TA that have been provided. Everything from helping folks achieve different capacities and increase their capacity, individual TA, reviewing plans, and doing a variety of different types of technical assistance and training. Key features of the ICCP is that we really strive to communicate, coordinate, and collaborate with lots of different organizations, and that in itself is a very difficult task, as you can imagine. But the perseverance and the commitment from the partners has been nothing but spectacular, and we really appreciate all of the partners coming together and focusing on what we all can individually contribute to the whole. Again, we're very clear about what our purpose is about, which is focusing on supporting the LMICs to develop and implement cancer plans. The other thing that we do is we really look at how are we measuring our success. So we look at not only internally, what are the measures of success as a partnership, but also what are our measures of success when we look at how countries are doing in this area. And then the other thing that we really try to do is balance that formality of needing some structure, but also being pretty adept and adaptable to things that come our way that maybe we weren't expecting. So final closing slides here is that the real key thing for developing and forming a partnership at the very beginning is to look at what's that value added piece that the partnership provides. And so what are we trying to looking at together, coming together and saying, what are we really trying to make different? What are we trying to fix? How can we improve something that's already out there? And then also, why us? What do we bring to the table? What does this partnership bring to the table that is not happening right now? And that's the other thing. Would this partnership work on things that wouldn't happen unless we came together and worked together? Or are these things that would happen anyways? And so then you have to question the importance of the partnership. So common elements of success. One is make decisions and filter ideas based on your purpose and mission. Very critical to have those decision-making criteria up front. It allows you to say yes or no to different areas, and it also defines the scope of the partnership. The other thing is to write down what you decide and to be very clear with roles and responsibilities. It's a critical piece of having a partnership work effectively and efficiently as you move forward. Be inclusive and work in communication. Again, these are volunteer for the most part partnerships, and so there should not be any kind of hierarchy or exclusion. Really, it's who wants to work on this and how can we work together the best. Be flexible. Change how you work. If something's not working, be assured that you have mechanisms in place to identify what's not working, as well as being willing to change either a structure or a way of working. Also, you can't see this, but focus on what you can agree on. It's really important. There's lots of things that we don't agree on, but by focusing the partnership on the things that you can agree on and those common goals will make all the difference for you in progressing forward. And evaluate progress in different ways. As I mentioned, it's really important to look at not only how the partnership is functioning, but really the impact that you're having on whatever the partnership's mission and vision is. And finally, really give attention to the process of working together. It's easy just to say we want to do this together and then just try to move forward, but forming a good, strong partnership based on some of these elements that I just went over is so important, and it so very much impacts the product of your work. So giving that attention to the process is just as important as the product. I thank you for your attention, and I appreciate your willingness to hear about these two different partnerships, and wish you the best. Thank you.
Thank you, Karin. Our third presentation and the final presentation will be given by Dr. Puneet Bains, a medical oncologist, a member of the Faculty of Medicine at UBC, and a director, a colleague, and a volunteer with Two Worlds Cancer Collaboration. Puneet has a strong interest in global cancer control initiatives, specifically in education in lesser resource countries. Today, she will be speaking on how partnership and collaboration can be used to educate and build programs in a self-sufficient and sustainable way with meaningful impact. Her talk is entitled Collaboration, a Shared Vision to Create Capacity. Puneet.
Good afternoon, everybody. My name is Puneet Bains. I'm a medical oncologist in Vancouver, Canada. I am also a volunteer with Two Worlds Cancer Collaboration. Today, I'm going to talk about a shared vision to create capacity. I'm going to discuss some of our experiences we have had with some of our collaborations in South and Southeast Asia. Now, a little bit of background on Two Worlds Cancer Collaboration. Now, Two Worlds is a registered Canadian nonprofit society. It is a strictly volunteer-based organization without facilities, without equipment, with the mission to bridge the disparities in healthcare and cancer control between the two worlds of higher and lesser resourced worlds. Now, Two Worlds was initially a Canadian branch of the INCTR. And the initial engagement in South Asia actually started in Nepal through our twinning programs in palliative care and hospice with between two hospitals in Nepal and hospital and partners in Nanaimo, British Columbia. Now, this picture here is showing the sun setting over the city of Kathmandu in Nepal. Now, this diagram here is showing our key concept, Two Worlds, closing the circle. Now, the goal here is a patient-centered approach integrating public and clinical medicine and coordinating care across the cancer care continuum and across age groups, curative and palliative medicine, across locations of care, so home, community, as well as tertiary facility-based care, and closing the circle through collaboration, drawing on the strengths of all partners to build greater capacity and capability. And of course, including the patients and families who are key to the closing their circle concept as well. Now, Two Worlds Cancer Collaboration mainly partners with organizations in South and Southeast Asia. Now, a little bit of background on some of the countries that we partner with. India, Nepal, Sri Lanka, and Bangladesh are home to approximately 1.5 billion people. Now, that's about 22% of the world's population. And this is in a land area of about 1.41 million square miles. Now, by comparison, Canada has about 2.5% of that population, occupying a land mass of about 2.7 times greater. Now, as much as South Asia is rural, it is still one of the fastest global urbanizing populations. And with that comes all significant health implications as well. Now, 2/3 of all all deaths are due to non-communicable diseases. It's no longer infectious disease. This includes cardiac, respiratory, renal, and of course, cancer. Now, a little bit more comparison in terms of Canada and cancer stats. 70% of adults in South Asia will die of their disease once diagnosed with cancer. In Canada, that's about 45%. Now, in South Asia, 80% of children diagnosed with cancer will die of their disease, as opposed to 80% being cured in Canada. Now, cancer is not a different disease in South Asia. It really is a difference in the ability to control cancer. And this is due to many, many factors, including differences in the Human Development Index, access to care, health awareness. Patients are often presenting at a later stage, which is more difficult to treat. Societal and financial challenges, distance, geography, distance to care, and the list goes on. Now, these parameters really do identify the differences between Canada and South Asia, and that they really are two different worlds. One high resource, one low to middle resourced, and great disparities even within the countries, as we all know. So how do we build collaborations to bridge this gap? Now, you know, the health and social circumstances in South Asia really are comparable to that of Western Europe and North America, like 70 years ago. We really need to bridge this gap because we don't want to wait another 70 years for their health systems to catch up. So let's collaborate and see if we can make this happen. And how do we make this happen? Collaboration. It involves a network of relationships. This diagram here is depicting how many different relationships are all linked, and that includes local governments, civil servants, NGOs, academia, community health workers, patients, the community, and donors. This web is very well interconnected. However, at the center of this really is local leadership. With an emphasis on local leadership, we need leadership on the ground to make any collaboration work. So establishing and supporting local leadership really is the key element. It is important to have on the ground leadership and team. They know what is needed, what is required, also have the commitment and motivation to make things happen. And with this also comes mutual understanding of the long-term goals. This is not a one and done situation. The goal is to build capacity and a sustainable programs. So what we don't want to do is come in, establish a program, and leave, and the program is no longer viable. That is not the goal. Goal is sustainability. Along with this comes long-term goals also. And long-term goals also include the eventual plan to transfer the care or the system to and within the local group and or government. That includes funding as well. And this is very much a group effort. Here in this photo is a group of Two Worlds Cancer Collaboration volunteers and our colleagues and team that we work with in India, in Hyderabad, India. This is from a recent visit a couple of months ago. This support really has to be built with a solid foundation to rise from, and the infrastructure needs to be set right from the beginning to build capacity and to sustain. Now, the team in this previous picture was situated in Hyderabad, India, which is the capital of the state of Telangana. Telangana has a population of about 35 million people, with 33 administrative districts that now provide healthcare within the state. Telangana is in southern India. It's highlighted here on this map. And again, about 70% of total disease burden causing death and disability is from non-communicable diseases. Now, this picture here is showing MNJIO, which is a government tertiary facility hospital for patients with cancer. In 2006, a palliative care program was started in collaboration with Two Worlds Cancer Collaboration. Today, it has become one of the largest centers in the regions for palliative care services, research, training, and education. Now, Hyderabad, the capital of Telangana, has been the major building block for the development of palliative care in South Asia. It's the only government-funded hospital in the region, and the center offers dedicated palliative end-of-life care, regardless of patients' ability to pay, religion, patient's ethnicity, open care to everyone. It is led by our champion on the ground, Dr. Gayatri Palat. She's the on-the-ground leader. Because of at this center, the center has grown now from an outpatient clinic to an adult inpatient unit, 24/7 home support, a 74-bed pediatric ward, community outreach program, and a hospice facility that is located within the city. The Hyderabad Center is now linked nationally and other cancer centers in India, and it has also become the training and support hub for activities in Nepal, Bangladesh, Sri Lanka, and the Philippines. So the idea here was think big, start small, find what works, and build and replicate your successes thereon. Now, this diagram here is just showing how an example of success in private and public relationships. So the Palliative Care Center in Hyderabad was done with partnerships of Two Worlds Cancer Collaboration, an international NGO, MNJIO, the Nilafur Children's Hospital, and Colonial General Hospital, so the local institutions, and the Pain Relief and Palliative Care Society, which is a local NGO. Now, in 2017, the government of Telangana actually decided to implement a program aimed to make palliative care accessible to Telangana's entire population. So the core Hyderabad Center helped the government of Telangana to establish centers in 8 districts under the National Program for Palliative Care. It involved capacity building of healthcare workers in a large scale, planning and execution of the project, and ongoing mentorship. And this district-based palliative care program in the state of Telangana really has become emblematic of scaling up. So starting up with a small center in Hyderabad, which is now expanded, now scaling up across the state. So from 2018 to 2021, 33 palliative care units have begun functioning in all districts, and from the most remote tribal areas to the metropolitan areas. This has successfully created 330 palliative care beds across the state, and on average, about 330 households are being reached by palliative care home care teams daily. It is considered a very successful model, which is replicable by the government of India, and the government has now taken over funding of all these rural programs. This model is currently being replicated in a pilot project in Nepal in collaboration with the local leadership of our Nepali partners. This pilot project is in Province 1 in Nepal, and if successful, plan to expand across the other provinces of Nepal, a country where 80% of its population is rural. And again, local leadership and partnerships in Nepal allow such programs to start from the ground up. We've also developed a collaboration within the northern province of Sri Lanka, and it is also strongly linked to the Hyderabad center in terms of education. It is not as large, but it is an example of scaling up using a network of common practice and vision. This includes a network of collaboration that includes those from Vancouver, Toronto, and the UK. This continued throughout COVID, and certainly there have been challenges, especially with the recent and current climate in Sri Lanka. Now, MNJO, as I mentioned, has become the hub of a hub and spoke model. Education is a key component of this model. This hub now provides a 6-week certification in palliative care with enrollment of healthcare professionals attending from various countries inside and outside of South Asia. There's also a specialist program, a specialist fellowship training program for physicians, nurses, pharmacists, and also observerships for different healthcare workers in the international settings. Now, these healthcare professionals are then better now able to provide care and further educations within their home countries after completion. This is a team-based interdisciplinary care is a practice model. And of course, recognizing that travel limitations imposed by cost, and also as we have all experienced, recent pandemic has shown us, technology-assisted training has really moved to the forefront. So using online, virtual, and real-time communication, for example, Project Echo, Zoom-enabled sport, WhatsApp, and now in-person visits as well as travel restrictions lessen. Now, this slide here is showing the different core educational training opportunities the Hyderabad Center for Palliative Care offers. All of these are multidisciplinary with a variety of learning opportunities and including lectures, direct patient care, case presentations, journaling. In 2021, we redesigned our existing pediatric palliative care fellowship program, launching a program adapted to the pandemic restrictions. The fellowship is a year-long hybrid program for physicians training in pediatric palliative care. The program combines online education, mentorship, and leadership, as well as leadership development from global experts and in-person clinical training now that the restrictions have lifted with the pediatric palliative care programs in Hyderabad. Now, the first set of fellows are from the Philippines, and once training is complete, the goal of these fellows is to establish a pediatric palliative care program in the main teaching hospital in Philippines, with continued and future training of future trainees, so building that capacity that is sustainable. Now, this slide here is showing the geographical scope of these training programs. From 2018-2022, the Two Worlds Cancer Collaboration has hosted about 2,300 participants in Project Echo palliative care mentorship programs. And these are all done with our partner organizations with a train-the-trainer approach. Now, Project Echo, extension of community healthcare outcomes, is a virtual model where local healthcare providers, the spokes of the hub and spoke, are connected with specialists at a hub site. Now, through regularly scheduled learning sessions, spokes connect together on Zoom calls and learn from the specialists and from one another. The patients benefit when they receive care from the providers at spoke sites who have now new knowledge and skills. The Echo sessions are typically conducted weekly or bi-weekly, depending on the course, and there may be a series of 10 to 15 sessions which are offered as a certificate course. Echo emphasizes moving knowledge, not people, trying to reach healthcare professionals with knowledge and skills where they are, instead of requiring them and their patients to undertake journeys to specialist centers which may be far from their homes. Now, this map over here illustrates the reach of one of our Echo programs. And you can see here at the bottom is a quote by one of the nurses and participants from Bangladesh. And she shares her experience by saying, "I feel my network has grown a lot more after ECHO. I got introduced to a lot more people that will help me to contact them directly." So we can see that the establishing networks can be across countries and within countries. And we also say that we do incorporate a number of national and local participants and allowing for mentoring of local leaders so they go on to produce their own ECHO sessions as well and pay it forward. Now, again, this image shows leadership team and partner organizations for an ECHO series in Nepal. And it, again, included key stakeholders and local leaders from Nepal. And having those key stakeholders from the country is quite key because these leaders are the ones that can ensure that the course is practical and relevant to that country and its participants. For example, they'll know which medicines are easily available, what will work, what won't work, will it be affordable for patients? And so involving local leaders provides them with an opportunity to learn from established ECHO leaders as well. And so the goal is that they can go on to run their own local ECHO courses in the future. And lastly, we all know behind the scenes, it takes quite a lot to make these meetings successful. So it's also important to ensure that there's adequate administrative support. So we want to make sure there's funding allocated to support these roles as well to make these programs successful. As I had mentioned earlier, we had mentioned the closing the circle concept and as a key element of Two Worlds goals. So more recently, we have expanded our collaboration into addressing comprehensive disease control across the cancer care spectrum. So this slide here illustrates our pilot program in India to screen for and detect oral lesions that might progress to invasive cancer. Now, oral cancer is one of the most common causes of morbidity and mortality in South Asia, in men and women. And quite often it presents at an advanced stage. And advanced oral cancer is quite challenging and it's difficult to palliate effectively and often can be fatal. And it can be quite a significant source of great personal and family socioeconomic distress. So projects and pilot projects like this need to be useful at a population level. Interventions need to be in the community using simple technology that is easy to learn and apply. And it has to be applied by appropriately trained and available personnel. Now, Two Worlds collaborated in partnership with the University of British Columbia, BC Cancer, and a team in Hyderabad, India, so the M&J Cancer Hospital, 2 dental colleges in India, and PRPCS, the local NGO. And then this undertook a 2-phase study. Initially, a first phase was feasibility study, followed by a pilot study. Now, it's important to know from the local team the resources and personnel that are available to make this program successful. And the team definitely needs to be motivated to move such projects forward. It does take quite a commitment as well. This involved monthly Zoom team meetings to develop personnel, informed consent, physical capacity, and capability and commitment to this protocol-driven research. So networking can be with countries, across countries. It can also be virtual. Another important aspect of networking is that it can build other partnerships and relationships in addition to the planned ones. For example, south-to-south relationships. South-to-south relationships also can be quite instrumental and can allow solutions to develop, knowing the similarities between each region. The pandemic and the advent of the virtual world and technology has really shown us that the world really is a smaller place and truly taught us that working together is very much possible regardless of the geographic distance. The ECHO sessions have also led to networking and continued mentoring, many of which use WhatsApp or Viber group chats for questions and cases and real-time patient support. So is it all worth it? I think most of us will say yes. And why do these things work? Now, for Two Worlds Cancer Collaboration, there's been about 15 years of learning and about how and why collaboration has worked, what has been successful and what is not, and what has been achieved. Now, the success of a collaboration is never guaranteed. Nothing is ever guaranteed. But it is important to keep in consideration factors that may help or hinder the ultimate success of a collaboration, including things that we can't control, such as political or funding issues. But this all often comes from experience. And then why do things work? We need a shared vision. To what extent is our vision shared with the group and our partners? And is it a true collaboration with a shared and common goals? This often very much requires transparency right from the beginning, and communication right from the beginning, right at the onset. Each party brings unique assets to the collaboration. It is a bi-directional and interdependent relationship. Now, Two Worlds brings a know-how from unconstrained resource settings and motivation to help that is not based in personal gain or glory. And our partners bring the local experience, profile, and reputation, context. And context is very important because they know the knowledge of the country culture. They know the professional and technical skills within the country and what is available. They know the practical and operational know-how, knowledge of critical relationships and etiquette, and they have a motivation to act to realize an achievable reality. Now, another key element is trust and mutual respect. One needs to have commitment and willingness to invest time. Now, we have asked our colleagues near and far what is important in establishing a partnership and collaboration. What is answered often is mutual understanding and trust. Mutual understanding of long-term goals as well. For example, one would be the work being done in India with Dr. Palat, who's pictured here on the right, in Hyderabad, India. And the program there is around building capacity and funding fellowships and building capacity in pilot projects, which would eventually, the goal being to transfer to in-country and government funding. So the other important thing is knowing context. There are often significant differences across nations in different capacities. For example, the differences may be in institutional and government relationships, which can differ across countries. Things run differently in India than do in Canada. And it may not really be necessary for us to know those differences, but to have our partners guide us through these differences and lead us through these differences. And again, as mentioned earlier, transparency right from the beginning. Transparency on the purpose, the process, and the expectations. Everything should be clear to the entire team. Now, when asked what doesn't work, one mentions arrogance and ego, which can really get in the way. This can also affect relationships and often can be quite subtle. And also lack of flexibility. One must always remain flexible. You must remain flexible to change and also unexpected circumstances. As we also learned to pivot, we all had to learn to pivot during the pandemic. One must also be curious. When we partner, be curious. Be curious with what our colleagues are doing. Where do they come from? What have they tried? What has and hasn't worked? And I'm back at it with leadership. Leadership is a key element. So we have our local leader here, Dr. Palat, on the right, on the left. And on the right, we have Dr. Megan Doherty, one of our leaders with Two Worlds Cancer Collaboration. There must be a champion on the ground with passion and purpose. And this leadership necessitates a dedication and commitment, professional expertise, time, and these relationships, again, span out across various organizations. Two Worlds really is a guest in another country. Our local partner is part of a national and state healthcare system in that country. The ability to achieve the goal of accessible, available care at the population level is dependent on collaboration of all these groups that are interwebbed and independently governed and all interconnected. Good governance of a partnership is also necessary. Now, impact and value. It is also very important to demonstrate impact and value, and that's important at the political level, national level, societal, and donor level. So this often requires measurement of process and outcome and reporting. So the ability to demonstrate the impact is important from a systems change perspective for the decision makers, but also to encourage and maintain donor support and philanthropy. Where is the money going, and is it being useful, and is it successful? So a successful collaboration requires that we understand not only the clinical context and clinical content of the challenge, but also the context of the country. The country can the country actually do what is required, and the relationship prevailing across the cancer control spectrum from patient to professional to systems care. We also need to understand the conditions determining success: leadership, the preparedness and readiness for system change and development, political, professional, societal alignment, strategy and the financial aspects of implementation, system capacity and capacity building. Is the workforce there with the resources to act? Relationships must be trusted and respectful if they are to be productive and sustainable. We want to remove all historic and stereotypic attitudes, behaviors, and expectations. Finally, what is implemented must become self-sufficient and sustainable through demonstration of impact and value, with planned transfer of evidence and activities and funding to the health system, with reinvestment of any spared resources into continuous innovation and system development. So how might this relate to the Canadian Global Oncology Network? So what we are at Two Worlds is a volunteer-based group, an NGO. We're clinic service focused, hands-on, grounds up, we're philanthropy dependent completely. We are not an institution or linked to an institution, but partnerships with such organizations and institutions can be beneficial. We all know and understand that there are many global needs across the cancer care spectrum, which is challenging for any one institution or group to overtake. There's a potential opportunity for networks, whereby the whole becomes possible through the sum of the individuals. In Two Worlds Cancer Collaboration, we refer to that as closing the circle. Now, we all know that there are many initiatives currently ongoing across the globe in many countries by many individuals and institutions. Now, and many of these actually we don't even know, they remain unknown to us. But these are all worthy causes. Now, the question is whether they could be more than they currently are. Could one address depth, scale, and scope of these programs? Could one create framework whereby activities are known, integrated, and coordinated? Could this be a role for networks, both within and between countries? Now, with that provocation, I will end. A question for all of us to ponder this as the meeting continues over the next 2 days, and as we all network virtually and in person, and we continue to collaborate. Thank you, and thank you also to my co-panelists today.
Thank you, Puneet, for that presentation. So we've heard 3 presentations from organizations, each of them approaching global cancer control through a different rationale and a different type of approach. And the intent of the presentations was not really to suggest that the Canadian network should either identify with or do as these organizations do. Rather, the presentations were to illustrate how these entities have developed durable, sustainable relationships that are enabling the cancer control ambitions of partners in lower and middle income countries. In short, based on their experience over many years, what are the critical underpinnings of collaborations that are impactful, mutually rewarding, and value added to the partners? Now, at the risk of interfering with your dessert and conversation, I'd like to say these 3 different organizations actually have presented us with many commonalities as to how they are achieving their goals with their partners. And I'd just like to mention them in preparation for our ongoing thinking. Firstly, the importance of being prepared and ready. Not solely are we informed, do we know what we're going to do, but also, are we resolved to act? And do we have some understanding of what is it going to take to do what we say we want to do? Secondly, the importance of a shared vision for what is to be achieved by the collaboration, rather than who the partners are. What is it we are going to achieve together? Working to achieve self-sufficient and sustainable interventions through long-term strategic relationships that are based in inclusivity, trust, mutual respect, and a shared vision. The importance of the health system as the fundamental enabler of health outcome change. Specific interventions depend upon all elements of a functioning healthcare system if the burden of disease is to be reduced at a population level. As Puneet has indicated, providing palliative and end-of-life care in lower and middle-income countries is absolutely essential. But as an intervention, it won't actually change the incidence and mortality of cancer. System change, in her words, closing the circle, is the route to reducing the population burden of cancer. My last point, the necessity for flexibility and adaptability, stressed by Karin, to evolve according to local circumstances, to shift priorities as necessary, to recognize the impact of global events such as COVID or changing financial conditions, to recognize program evolution as outcomes and outputs of the program change, and to use one's presence and one's relationships to engage more broadly in collaborations both within and between countries to improve health and disease control. I'm hopeful that this session will set the scene for a moderated panel discussion tomorrow, and also for ongoing conversations between all who are participating in this Canadian oncology workshop. I know that we are all focused on how can we help reduce the burden of cancer in lower, lesser and middle-income countries. And that, I think, is an ongoing discussion for the Canadian Global Network. And I look forward to those conversations in the panel discussion tomorrow. Now, I would mention in closing that I've noticed the private chat line and the comment line, and I'm not aware of any comments or any observations. The time is now 7:15, and so I'm going to hand back to Ziv Rosberger and invite Ziv to initiate any further conversation he would like to have in the remaining time, or to close today's session. So thank you very much, and I'll hand you now back to Ziv Rosberger.
Thank you, Simon, for organizing the initial session, for bringing these issues to the table. I think they're highly stimulating, giving us a tremendous overview and looking at the big picture. Are there any questions from people here or comments that you'd like to make? Anyone want to come in? Anyone want to dive in? So I'll just, Simon, I've asked you this question before, and we've had this conversation about some of these issues. One thing that was stated very close to the end of the last presentation is that Two Worlds is, and we've had this discussion, is philanthropically driven. And, you know, money talks, and if you don't have a little bit of money, so we have two hats that we have to wear. We have to wear the hat of fundraising at certain points, as well as performing our professional activities and networking and seeking partnerships. Could you comment on the challenges around that and perhaps give us some advice about these particular challenges?
Thank you, Ziv. Thank you, Ziv. And the point that I think is very important here is that when you come into a collaboration or a partnership with a lower and middle income country, it is worthy and noble to want to be helpful. But unless one can actually put that collaboration into practice, and that requires money, unless you can do that, unless you bring something to the table other than goodwill and expertise, then it is very difficult to mobilize a meaningful, durable route to self-sufficiency and sustainability. So, as I say to my colleagues in Two Worlds, it's great to want to be helpful, and it's great to be a good partner and understand how to do that. But at the end of the day, we are also a fundraising organization, because we have to come to the table with the ability to help, and help means infrastructure, and that means financial support. Now, for government-funded institutions, the question becomes one of the imperative of this global health activity to the organization and to its sources of funding, be they government funding or be they foundational support. And that's a question for each organization to address. I think we would all say that increasingly global health and global cancer control are becoming components of our academic endeavors. And there is a recognition that Canada as a country is in a position and should be helping to support global developments, given its status, its achievements, and its abilities. As NGOs, those same constraints or those same opportunities don't apply. As an NGO, one has to raise money, and raising money is really the ability to express a case that causes people to believe that their donations will change outcomes and help the cause that one is bringing forward. I think what we'd all like to see is that our activities enable lesser resource countries to become self-sufficient and to work internally to sustain the changes that they have demonstrated to be valuable. So it's not that we want to continue to fund in perpetuity, it's that we want to build and we want to assist. But if assistance is to be valuable, it has to be embraced within the health system of the country. So I think, Ziv, as we look at this as a Canadian network, I think we have to look at a mixed approach to how we fund the ability of a Canadian network to support the activities with our partners in lower and middle income countries, recognizing that in raising that money, we have different obligations to our funders, and we have different abilities to use the money in ways that the donors may intend. But at the end of the day, the ability to have infrastructure, the ability to support a network, and the ability to come to the table in a way that helps build capacity makes an investment in a country's ability to educate and create self-sufficiency in its abilities to control cancer. I think that is the route that we should be thinking about for the future.
Thank you. Well put, in only the way that I've come to know Simon can put it. He can articulately point out where our challenges are and where our opportunities are as well. So, any other comments or questions anyone would like to pose? Too much alcohol in the room, I think. Melissa, come to the mic, Melissa, please.
Hi, thank you very much. I guess on another note, there are issues around potentially colonialism and how we're perceived as an outsider when we're coming in, when we have lofty goals, but at the same time we need to deal with a different culture. And I'm wondering how, what's the best way of navigating that? in our implementation of programs.
You've raised a point that's very current in thinking about collaboration and partnerships in this regard. The heritage of our coloniality, the arrogance of high resource westernized countries, and the tendency to be paternalistic and believe that assistance is a one-way street from high resource to low resource. And I think the key thing in my mind to address that is one shouldn't come to the partnership as an outsider or as a high resource country. One should come to the partnership as a partner to solve a problem with partners in the country that one is working with, i.e., essentially become the insider with the country that you're working with, and change the relationship from the outside looking in to we are all inside. We're inside in the particular context and circumstances of your country, and we're here to solve a challenge that you have identified is really important for your country and your population. It removes us from it's really about us and we'll do it with you, to no, it's about what you want to see happen, and it's about our ability to enable and help you do that. I don't think we can't atone for colonialism, and I don't think we should reconstruct a neo-colonialism. I think that we should embrace the challenges that countries have and join them in a shared vision of how we can help solve those particular problems. In effect, we become one of them, solving the problem that faces their population.
And if I can just add, for my own experience of the last couple of years in the work that we're trying to do as well, in a project in sub-Saharan Africa, it's very easy to slip into that colonialistic frame of mind. It's a slippery slope, and one that we need to be mindful of. That's been my experience. I find myself finding when I'm frustrated and things aren't going the way I think they should, I begin to realize that I'm slipping back into I know better than you, and that's something I think we have to be on a constant watching for it. Any other?
Simon is on mute.
Oh, Simon, you're on mute, Simon. There you go.
I just want to reinforce what you said, Zeev, in the context of there is enormous wisdom and knowledge within countries, notwithstanding they are lesser resourced. And I think colonialism has tended to say that's not really important. It's our knowledge that's important. And I think we must come to these relationships with the open-mindedness that we are all learning. The question is, how are we going to do this best together?
Okay. If there are no other questions, we're coming to the end of the evening. Thank you very much, Simon, for organizing this session. I'd like everybody to be reminded that the last session tomorrow will hopefully reflect what we've talked about, what we've heard today, and what we've heard all day tomorrow, to sum up and have a final discussion about where our network, where the Canadian network, where Canadian healthcare professionals can go. I think that the agenda is set, and looking forward to tomorrow. So we'll close tonight's event, and we will see you tomorrow morning at the McIntyre Medical Building on the 3rd floor. Please come before 9. We're going to start at 9. Dr. Hijal will be the moderator for tomorrow's session, and look forward to a great day tomorrow. So have a great night and drive carefully, and we'll see you tomorrow morning.